IgG4 related disease in ENT. IgG4 related disease is a pro inflammatory immune mediated systemic disease characterized by dense lymphoplasmacytic infiltrate rich in Ig4 plasma cells. There is storiform fibrosis and there will be often elevated serum Ig4 levels. Multiple systems like pancreas, salivary gland, orbit, thyroid, or retroperitoneum can be affected. Etiopathogenesis, it is unknown idiopathic disease mainly leading by allergic autoimmune activation related to T helper cell, interleukin 10, tumor growth factor beta that lead to fibrosis. ENT manifestations are salivary glands lead to chronic sialadenitis, lacrimal glands common presentation is orbital pseudotumor, in thyroid like renal thyroiditis and Hashimoto variant. Nose and sinuses may lead to chronic rhinosinusitis, which is unexplained, mass-like lesions. Larynx and trachea, subglottic and tracheal stenosis, ear mainly OME and mastoiditis can be seen. In salivary gland involvement, there is Mikulicz disease, Kuttner tumor, and chronic sclerosing sialadenitis. These diseases initially thought as a separate entity, now under IgG related disease. In Mikulicz disease, there is bilateral symmetrical, painless swelling of the parotid and submandibular glands. Most common gland involvement is the submandibular, followed by parotid, followed by sublingual, and at last is the minor salivary gland. Often presentation are there is dryness in the oral cavity, there is absence of anti-Rho and La antibody to differentiate from the Sjogren syndrome, and these lesions respond well with the steroids. These IgG4 related disease may present in the nasal and sinus diseases, like they present with unexplained chronic rhinosinusitis. There are mass-like lesion in the nasal cavity or sinuses. There is orbital involvement via eth mode extension is also there. They mimic like GPA means granulomatous with polyangiitis. Biopsy is the diagnosis of nasal tissue or sinus tissue to differentiate from other causes of the chronic rhinosinusitis. Diagnosis can be done by clinical, serum test, and biopsy. There is organ swelling or dysfunction like in Mikulicz, salivary gland swelling is there. In thyroid, in renal thyroiditis, there is thyroid swelling is there. There is elevated serum IgG4 level more than 135 milligram per deciliter. That is supportive but not mandatory. Imaging, you can do CT, MRI or PET scan according to the lesion or site involvement. Biopsy is the gold standard that shows 10 IgG4 plasma cells in per high power field. There is Ig4 to IgG ratio is about more than 40%, and there is storiform fibrosis and obliterative phlebitis is there. You can do immunohistopathology. In that you can see there is extensive fibrosis and abundance of the Ig4 plasma cells is there. Differential diagnoses are Sjogren's syndrome, sarcoidosis, lymphoma, granulomatosis with polyangiitis, and tuberculosis. For management, if patient is asymptomatic, no therapy is required. If patient is symptomatic, there is short course of corticosteroid can be given, like prednisolone 30 to 40 milligram per day for induction, and you can taper the dose according to the lesion and disease. And you can give immunosuppressive therapy like rituximab anti-CD20 for the relapse and refractory cases. You can add azathioprine, methotrexate, and mycophenolate mofetil if patient is not responding to steroid. Prognosis and monitoring. There is good response to steroids in most of the cases. You can monitor by clinical response, serum IgG4 level, and imaging of serial imaging of the lesion like PET or CT. There is risk of fibrosis and permanent organ damage is there if treatment is delayed in the symptomatic cases. In summary, IgG4 related disease is a masquerader, mimics tumors and chronic inflammatory diseases. Early biopsy is key for ENT presentation. Treatment is mainly steroid plus minus immunosuppressive therapy. You have to recognize the pattern of disease and you can prevent the systemic progression by adding the appropriate timely treatment. Case presentation. A 52-year-old female patient present to me with bilateral neck swelling with cheek swelling, and there is no fever, pain, or pus discharge. There is mild xerostomia but no ocular dryness, no weight loss or systemic presentation. On examination, there is bilateral symmetrical from non-tender swelling in the parotid and submandibular region. Overlying skin is normal. There is no cervical lymphadenopathy. On investigation, there is serum IgG4 level is about 210 milligram per deciliter. ANN anti-Ro antibodies are absent. Ultrasound showing diffuse enlarged salivary gland, no focal lesion is there. FNAC of submandibular gland showing polyclonal lymphoid infiltration. There is core biopsy is taken and there is dense Ig4 plasma cell infiltrate more than 100 per high power field. There is Storiform fibrosis there and ratio of Ig4 to Ig about more than 50%. So this is a case of Mikulicz disease which is IgG4 related chronic sialadenitis. For this lady, treatment is Prednisolone 40 milligram in tapering dose given for the 3 month. There is dramatical response and regression of gland swelling in 4 weeks is seen. For maintenance, you can taper the dose low dose steroid for 6 months and you can repeat the serum IgG level after 6 months. If there is no relapse after 1 year, you can review the treatment and you can give according to the response of the treatment the therapy and you can monitor by IgG4 level or image serial imaging for this patient.